Thank you very much. My name is Noel Gibney. I'm an intensivist from the University of Alberta. And I think we've got a treat for the next 40 minutes or so. We've got three of the leaders in the area of critical care nephrology, and each of them are going to talk to us for 10 minutes on their favourite idea in acute kidney injury and renal replacement therapy. And our first speaker today is Dr. John Kellum, professor from the University of Pittsburgh.
Thanks, Noel. So let's just jump in. So hypothesis, cancer drugs have a role to play in the treatment of AKI. Manipulation of cell cycle arrest in tubular epithelial cells will improve AKI. So that's kind of a wild idea. How would that work? Well, in cancer, we have a situation where malignant cells evade chemotherapy by temporarily shutting down their metabolic function, going into cell cycle arrest, not proliferating. And so cancer biologists have actually been trying to develop techniques that force these cells to proliferate so that they can be attacked by chemotherapy. In AKI, we have renal tubular cells that enter cell cycle arrest and that downregulate their metabolism in response to stress. That's good. But they also, if they stay in cell cycle arrest, they develop a senescent phenotype which promotes fibrosis, and that's bad. In addition, we now have biomarkers that appear to be associated with this cell cycle arrest phenomenon. Can we pair the biomarker with the timing in such a way as to force cells to go into a protective stance when we want them to, and to come out of their protective stance and to proliferate when the threat has passed? Well, the earliest evidence of this comes from our study in remote ischemic preconditioning, where you can clearly see that by putting a blood pressure cuff on the arm of patients about to undergo cardiac surgery, you can stimulate the release of TIMP2 and IGF-BP7. Now, we don't know whether that is associated with a protective phenotype at the cellular level, but we do know that patients who underwent this procedure had less acute kidney injury and less subsequent stimulation in terms of TIMP2 and IGF-BP7, whereas sham patients had no such protection. We also looked at injury markers. Here's NGAL, and again, you can see that patients that underwent remote ischemic preconditioning had substantially reduced injury to the kidney as measured by plasma NGAL, by urine NGAL, compared to sham. And we know experimentally, this is an experiment that we did with animals that were treated with cecal ligation and puncture to induce sepsis, and when they were treated with cyclosporin, you can see that the animals that received the cyclosporin here 18 hours after CLP had higher levels of TIMP2 and IGF-BP7 in the urine at 6 hours, but by 24 hours, this phenomenon had reversed, and you can see that there was protection in terms of acute kidney injury as measured by rifle criteria. Also not shown here, there was protection by histology and by injury markers. Now, there's other ways of approaching this which have also been explored in cancer, and looking at bioenergetic conservation using ICAR. This is some preliminary data that was presented in abstract form yesterday, and I'm just showing you here that there's a potential to improve outcome in sepsis and with less acute kidney injury using ICAR as a way of maintaining bioenergetics, whereas compound C has just the opposite effect and results in rapid death of the animals. So there may be an opportunity to induce cell cycle arrest at the early stage or potentially before the injury occurs. We might do this with cyclosporin. We might do this with actually giving TIMP2 and IGF-BP7. How we deliver those to the kidney is not completely clear, but they are small enough to be filtered at the glomerulus. Remote ischemic preconditioning may induce these molecules, so that may be effective. But there are a variety of drugs which have been developed, some of these as chemotherapeutic agents, others as drugs which will be familiar to you, which induce cell cycle arrest. The idea, my favorite idea, is to use the biomarkers to know where you are in the cycle and then induce cell cycle arrest and other protective mechanisms early, and then later force the cells back into cell cycle progression, again with agents that have been developed for either cancer or using anti-TIMP2 or anti-IGF-BP7 as a way of stimulating cell cycle progression and regeneration and repair. And with that, I thank you for your attention.
Thank you, John. Are there any questions? I see Stuart.
Thanks, John. Always forward-thinking as usual. I'm just interested in cyclosporin as a nephrologist who takes care of kidney transplants, and what cyclosporin was terrible as an induction treatment at high dose, and thought to cause delayed graft function. And so, how are we going to thread the needle when we're dealing with a pure ischemic situation like renal transplant? And how does that move forward with or relate to sepsis at all? I'm just interested that cyclosporin, which we've been taught to stay away from, might be something you're advocating.
Yeah, so excellent question. And as you know, much of the toxicity associated with cyclosporin comes from its repeated use rather than as a single dose. These doses that we gave the animals were comparable to not an induction dose, but a single low-dose therapy that you might give a patient with maintenance therapy for transplant, very similar to what we're currently giving lung transplants and things like that. So I think it would be well tolerated. It's actually a drug that, although has significant renal toxicity when given repeatedly or at high dose, a single dose should be very well tolerated. And this is a drug that's actually been around for many, many years. I think the drug is older than Zoltan, well, maybe not quite that old, but it's certainly been around for a while. It has a significant safety profile. We know quite a lot about it, but it has a lot of off-target effects, and so it may not be the right drug to have on this list. I put it there because we have some data around it, but it affects the transition pore in the mitochondria, it's anti-inflammatory. Some of these things may be very good off-target effects, but it's a messy drug, and there may be better opportunities to induce cell cycle arrest and other protective mechanisms with other types of chemotherapeutic agents. Ravi, you're from San Diego, right?
I believe so.
Okay.
So, John, I think thank you for that fascinating idea, but let me take it one step further. You've alluded to cancer drugs, and we know, and you've alluded also to how the oncologists use different tactics to do different things. In the AKI field, we've been kind of stuck with saying one type of thing has to work. How do you envision that we would in the future be able to harness different pathways and target them? I mean, hypertension as an example, we use every single pathway, we block it to get a blood pressure down. Do you envision a similar multi-drug approach coupled with something for us to be able to get there?
So it's a great question, and I think buried within that, maybe intentionally, is the complexity around timing. So what I talked about in the last session was this very interesting phenotype where early on versus later, you have very different responses with regard to what might be beneficial early on or what might be harmful early on might well be beneficial later. And I think the same thing is going to be true here. The last thing we would want to do is force a cell into cell cycle progression when the cell is being injured, because that will result in apoptosis and cell death. Whereas if we let the cells stay in cell cycle arrest for too long, they'll induce a senescent phenotype, and that may result in fibrosis. So timing is really going to be important, and it isn't until we have a better handle on how to measure that timing with direct biomarkers that focus on the various pathways as you described. So I do think there's an opportunity to use different things at different times, and then probably you're right. It's a function of thinking about multiple different approaches, not just a single one. Sir.
Yeah, lovely talk. The idea of using...
I'm sorry, could you speak up a little bit?
The idea of, you were just saying, you partially answered my question, which is how do you know when to get the cell to go out of cell cycle arrest without the risk of causing an energetic crisis for the cell and inducing apoptosis? So how are you going to determine when there is enough blood flow or there is enough energetics around for the cell to do it? Are you proposing you measure AMP kinase or looking at some of those other pathways that are for cell energetics? Because I can't see that just measuring the biomarkers per se are necessarily going to tell you that.
Yeah, I don't know, but those are excellent ideas. I think we should have conferred before I gave this talk. I think I think that's exactly right. I think that as we move forward in modifying this, and again, I just want to allude to something that Peter had said early on. I think we have to be smarter than just coming in and suppressing a response. We have to figure out what the kidney is doing well to protect itself and facilitate that. I think where we can be smarter is we're anticipating events that the kidney can't know about. So the kidney can't know that it's going to undergo the patient's going to undergo cardiac surgery. The kidney can't know that now we've got source control of sepsis. And so when the kidney is undergoing its usual protective mechanisms and its regenerative mechanisms and all of that's happening, we at least have the ability to know what else is happening and try to inform the kidney, hey, it's okay to go and do X. It's now not okay to do that because we're about to give you something else that's really bad. So, I think that's where we're going to get to, but I like the suggestions.
Thank you very much, John. So now I'd like to welcome Dr. Claudio Ronco, who's from the Department of Nephrology, Dialysis and Transplantation at Vicenza, Italy, who's going to tell us about his best idea in AKI and CRRT.
So thank you very much, Ravi, for putting together this strange session, because you force people to nail down what the best idea is. And what I try to do is to figure out at least if I had an idea. And I try to discuss something that I've not been discussing in other talks in this meeting. So, we know one thing. In AKI, there is an imbalance between pro and antioxidant factors leading to potential tissue damage. One of the mechanisms. On the other hand, we know that in CRRT, blood-membrane interaction may lead to production of reactive oxygen species contributing to the damage. At this point, I believe, you asked me to prepare this first slide, that taking advantage of new membrane manufacturing processes and membrane surface modification and functionalization, we can probably perform an antioxidant CRRT. And I will tell you why. Oxygen stress occurs when the formation of reactive oxygen species exceed the body's ability to metabolize them. Oxygen stress is a common pathway involved in cellular dysfunction, tissue injury, and organ failure. High level of oxygen radicals inactivate mitochondrial enzymes, cause DNA damage, induce base hydroxylation and strand breaks, leading to cell injury and apoptosis. So injury caused by oxygen stress occurs in many clinical scenarios, including AKI and sepsis, and kidney being rich in mitochondria and therefore is highly vulnerable to damage caused by oxygen stress. So oxygen stress in AKI is one of the mechanisms definitely that may lead to tissue injury. However, we should consider the possibility at least to modify one of these mechanisms that seems to be present in several forms of AKI. And in fact, if you look at the advanced oxidized protein products in critically ill patients with AKI, you immediately find that their levels are much higher compared to the same level in control patient in ICU without AKI. Not only that, but their level seems to be higher in proportion with the progression of severity of AKI. So this is another interesting observation. At the end of the story, I think that oxidant stress is part of the mechanism by which also acute kidney injury affects distant organ injury. And I think this is another important aspect to consider. So the contact of blood with artificial membrane during CRRT normally results in elevated production of reactive oxygen species and AOPP by activation of leukocytes. At the same time, AKI patient lack of several defense mechanisms. So in addition to antioxidant therapy by IV or other ways, we can probably use vitamin E coated membranes to decrease oxygen stress. Now, we have today different possibilities to functionalize the surface of membranes. And in this case, there is a membrane that has been functionalized with alpha tocopherol on the surface, making the membrane more hydrophilic, more biocompatible, and exposing sites that may actually act as a scavenger for reactive oxygen species. The idea is that direct scavenging of free radicals on the membrane surface, directly where part of them are generated, is attractive. And the idea is that, as you can see here, we may achieve control of protein oxidation, reduce LDL oxidation, and probably also reduce erythrocyte damage through this mechanism. When ROS meets alpha tocopherol, it donates electron, and therefore ROS are deoxidized. So what is the advantage of acting directly on the membrane? Practically, it may be preferable than giving antioxidant through other ways, because you don't know whether they reach the target, and at the same time, you don't know what the compliance or the bioavailability may be. I think that the effect of on ROS is exerted to an in situ action in this case, and therefore on blood cells, and not through the release of vitamin E. As a fact, we did some measurement of vitamin E released by this membrane, and functionalization is pretty stable, so vitamin E remains there. So this results in improved biocompatibility of the membrane with less activation of leukocytes and production of inflammatory cytokines, as well as decreased endothelial cell activation due to scavenging of ROS from vitamin E. This is a very preliminary study. We just did it a couple of weeks ago, in which we had a group of AKI patients in which we treated with 24-hour with the vitamin E coated membrane versus a non-vitamin E coated membrane. And after 1 hour, after 12 hours, and after 24 hours, you see the difference in the level of these macrooxidized proteins. And it seems that there is a signal that at least deserves to be explored. So probably, as we have specific drug for specific patients, we might need specific membranes for specific patients, especially for patients that have a high oxidant stress. And this can be done through the evolution of the membrane to a different dimension. Now, when we started with the cuprophane membrane, we were afraid about poor biocompatibility. For this surface was modified, and in fact, different membranes, especially synthetic membrane, became more biocompatible. Then we were afraid that flux was not enough, and we developed a better porosity, inducing an increase in flux and permeability. And now we are getting to a different dimension in which we increase the bioproperty of the membrane by functionalizing the surface of the membrane itself. So in conclusion, I think that antioxidant strategies may be important in AKI, sepsis, CRRT, and vitamin E coated membrane may represent a future interesting application. Thank you.
Any questions for Dr. Ronco? While Ravi's getting up, oh, here he is. Good.
there is a fellow from San Diego.
Claudio, fascinating, and I think you've hit on something very important. But would you care to comment a little further on this? And saying is, you've sort of said that the membrane can reduce or improve the biocompatibility at the membrane level. But would you take it one step further and say, if the process is systemic and continuous therapies are continuous, could you actually use these devices in the way you think of them to be more of a sink and readjust the milieu in the actual and restore homeostasis in a way by using the therapy?
Certainly, this was the original idea, but I didn't want to go that far because we don't know many things. When you functionalize a membrane, you don't know exactly when this new function added to the membrane is getting saturated. So these are things that we need to study. Although we know that a large surface areas membrane can exploit the great activity, for example, of adsorption. In this case, probably they may also operate bioactivity depending on the surface area. So definitely this is possible. The other thing is, believe me, we don't know what could be the effect of a very marginal blood flow in the extracorporeal circulation compared to the overall circulation, systemically speaking. But certainly, if there is a signal at the beginning of our exploration, I think that this deserves probably to go further, and then we may design different filters, different surface area, different membranes. Maybe we'll discover that we need to change the membrane more frequently. Certainly is an area of completely open research.
Claudia, lovely idea. I'm not really clear how well circulating pro-oxidant activity affects the kidney at all, at least in AKI. So I think there's an issue in relating cellular events with circulating factors. On the other hand, I wonder if this membrane might not be useful for regular dialysis in normal patients, who a significant number of whom on regular dialysis actually have a lousy time. A very substantial number of our patients find dialysis an exhausting procedure, spend the next day actually resting up, and are debilitated through the process. And we don't really understand whether it's hypotension, some other delayed bioincompatibility, modification of various hemodynamic factors, etc. So, in my opinion, modifying and functionalizing the membranes in a biologically attractive way is interesting anyway.
We have been using this membrane in chronic dialysis patients now for 5 years. And the observation that we have made is that in these patients, the requirement of erythropoietin is slightly reduced compared to other patients. It's a single-center observation. We cannot probably consider this as a robust evidence, but nevertheless, this is our observation. The point is that once you start considering functionalizing the surface of the membrane, I have studied industrial chemistry for understanding a little bit better, and there is an entire universe of possibility to functionalize the surface, modify the pores, using nanotechnology to change. So I think that research in the area of membranes that has been considered a little bit a dead end probably may restart to become interesting due to this fact. The other aspect is, certainly, we are only affecting the humoral circulating component. And we're not probably acting at tissue level unless there is a kind of equilibrium in which we can remove substances from the interstitium, from the cells through a cascade by removing from the blood. But I think that probably part of the damage is definitely occurring because at the systemic level, at the circulatory level, there are humoral substances that act in paracrine or even endocrine modality that are not supposed to do that.
Agree with that.
Thank you very much, Claudio. And our last but not least speaker this evening is Professor Jean-Louis Vincent from Brussels, who's going to tell us about his favorite idea in AKI and renal replacement therapy.
Well, thank you very much indeed. And I think Dr. Mehta wants me to be a bit provocative, I suppose. At the end of this excellent day, I have a confidence to make. I don't like AKI. How could these letters be put together? Is there anything in life more ugly than AKI? AKI. I have heard it 3,954 times today, and it still hurts my ears. Why AKI? Already ARI would be much nicer. ARI. AKI. ARI. ARI in French means laughed, which is good. Or acute renal dysfunction? ARD, ARD. Oh yeah, it sounds a little bit like ARDS, right? But precisely, acute kidney injury was developed largely to have a parallelism with acute lung injury, which was considered as a mild form of ARDS. But we abandoned it. We abandoned ALI. That's over. We had a meeting in Berlin where we said, no, acute lung injury, no good. We will just maintain ARDS. And still ARDS, as a syndrome, has not helped us very much to develop new therapeutic strategies. I just signed this paper saying, do we actually need ARDS? Why do we need it for? Well, it could be a sign of severity, which is not AKI. AKI could be mild, of course. ARDS is always severe somewhere. And then there is a yin and yang. It is that when you have the diagnosis of ARDS, either you would look for a cause, that's good, because you see ARDS, you say, I must look for a cause. Or, and that would be bad, we no longer look for a cause because we think that we have a diagnosis, which is just a syndrome. And that would be bad for the patient. So I'm not so sure that we need ARDS. And the parallelism with AKI is that we have not found anything effective in the treatment of ARDS. Nothing. We still speak about the possible role of steroids. We are not sure. There is no specific treatment for it. So why can't we speak about renal failure? I have raised the question many, many times, and still I have not heard any answer that satisfies me. People say, no, you should not consider that the kidney has failed. But what is circulatory failure? What is cardiac failure? What is respiratory failure? All of these could be transient. So what's wrong in talking about renal failure? It seems to be avoided altogether. No. Well, we could speak about renal dysfunction as we speak about liver dysfunction, neurological dysfunction, or hematological dysfunction. You don't care? Well, it has some importance. Do we sometimes see patients with only renal dysfunction in the ICU? It's very rare, very rare. In the ICU, they usually have multiple organ failure, and we count our fingers to have the 6 possible organ dysfunctions. The order doesn't matter, but renal dysfunction is there with circulatory, respiratory, hematological, neurological, and hepatic dysfunction. The kidney is one of our organs. Some of you may think it's the most important organ above the belt, but I'm not so sure that we can say that. Our patients usually have multiple organ dysfunction. So yeah, we can characterize renal function by creatinine and urine output. We'll agree on this. But exactly as we can characterize the dysfunction of other organs, and we can put it together. We all agree that timing is very, very important. A minor increase in creatinine levels over a few days' time may have profound prognostic implications. We have known it for a number of years. The same is true in cancer, for instance. Any mild increase in, a slight increase in creatinine could have a profound effect on outcome. Well, is associated with much worse outcome. A more recent study here in heterogeneous groups of critically ill patients. So, yeah, we need to look at the time course. We need to look at trajectories. Moderate increase in creatinine, mild increases, or creatinine levels which are high to start with and then stay elevated. With organ dysfunction scores, you can actually put together the renal dysfunction with the dysfunction of the other organs. And it's quite easy to assess the changes in renal function over time. With the rifle, Akin, or KDIGO approaches, it's a little less evident to look at these time course of renal function. Moreover, we sometimes lack the initial value that things will come from. So, with an organ dysfunction score, we have learned for many years, we published it 15 years ago now, that we could evaluate the changes in organ function over, let's say, 48 hours or 72 hours. And this has very sound prognostic implications. But the point is that we do not focus only on the kidney, we focus on the organ function. And we also reported that the time course of organ dysfunction in acute renal failure is very important. So are we really all speaking about the same thing? Do we have only one language? It's actually quite depressing to see that we do not characterize renal dysfunction better than we do. And then we try a therapeutic intervention, and then we end up with curves that look like this, and we publish it in the New England Journal of Medicine, and we say, another negative study. Hemofiltration or hemodialysis? No difference whatsoever. Early versus later onset of renal replacement? No. High intensity, lower? No difference. High volume standard? No. High volume hemofiltration and post-cardiac surgery shock as just published? No. But everybody goes down to precision medicine, except in our field of intensive care medicine, where we are still up there studying poorly characterized patient populations and ending up with many negative trials because we have two heterogeneous groups of patients. So my favorite idea is that we should better characterize our patient populations. They are not all the same. And in the field of sepsis, we are really changing now our strategies, focusing on endothelial cell dysfunction, focusing more on immunostimulation, as we heard this afternoon, focus on organ function, and use of biomarkers. And hopefully we start to have these biomarkers for renal dysfunction. And hopefully we will use them to better characterize the patient populations. There is really something very important there, because in the field of new therapeutic strategies in critically ill patients, instead of counting the number of patients who die and patients who survive, actually we could focus more on the organ function, as we do, for instance, with alkaline phosphatase, which was initially proposed as an anti-dump, as recalled today. And we used it in sepsis, and then we realized that perhaps there was something on kidney function. So that now we embark on this other clinical trial evaluating the effects of alkaline phosphatase on the kidney. And I think it's just one example, but which is quite interesting. So my favorite idea is that biomarkers will help us to better characterize the patient populations. We just wrote this piece, which has just been accepted by the Journal of Thoracic and Cardiovascular Surgery, where we propose to add NGAL to the usual criteria for renal dysfunction after cardiac surgery. And this may be a way to better characterize the renal function of these patients after major surgery. It's just one example on how we could perhaps move forward, view the future, going from these poorly characterized patient populations, just looking at creatinine and urine output and then randomizing the patients for one strategy versus another, to hopefully personalized medicine. If we cannot go into precision medicine, it will take a while. We are not oncologists, but at least going into more characterized or better characterized patient populations. I think we are going in that direction, and we should really strive for this, because that's how we will make progress. Thank you.
Thank you very much. Are there any questions for Professor
Dr.
Vincent?
Mehta has a question.
If not, I think next door we have our reception, and
I think, John Louis, thank you again for us. I want to tell the audience why this session came about. So I had the privilege of being with John Louis and John Marini in a conference about 2 years ago, and they set a session like this, and they put me on the stand to talk about my favorite ideas. So I thought I just have to take my revenge back in a way, because I think the key here is that these are untested ideas, but it forces you to think a little ahead and to try and put forth to everybody, exposing yourself to this. So, John Louis, thank you for doing that. I think this is really the right approach. I think the question I have for you is, we talk about these various biomarkers. Where do you think is going to be the mix of functional genomics along with, say, biopsy? Because one of the problems in critical care medicine and for us in the field of AKI is the lack of histology. And I think that's, other than oncology, where you got everything tissue, you got a diagnosis, you got everything else, how do you see those coming together?
Well, that's a very good question, and we do not have easy access to biopsies for the other organs either. I mean, you don't do lung biopsies so easily, and we still do autopsies in our institution quite regularly, but it's very difficult actually to have something meaningful out of the kidneys. Perhaps we don't do it very well, but it's very difficult to characterize renal dysfunction from autopsies of patients who died in the ICU. What you are saying is, I mean, of course, when we speak about biomarkers, and my approach was, of course, quite superficial, there are a number of approaches that you could consider, and indeed, gene expression could be really very interesting. I just reviewed a paper for a major journal with beautiful data on immunosuppression already at time of ICU admission. You know, throwing away this idea that initially the patient is in a pro-inflammatory state and then the patient becomes immunosuppressed. No way. 41% of patients had an immunosuppressed profile from ICU admission. And we spoke earlier today about the superb studies from Wong on children with septic shock, showing how the genetic profile could modify the response to steroids. Some of these patients with septic shock would actually benefit from steroids administration, but others would be harmed by this. So there are a number of strategies that we can consider, from simple biomarkers that we spoke about today to gene expression and even genetic factors, especially in children. So clearly we have a number of strategies that we can consider.
Thank you very much. Thank you, everybody.